Alright guys, in today's lecture I am going to combine 2 days worth of material in one recording or one video recording. I'm combining SLE, which is scheduled for April 1st, and RA scheduled for April 3rd. Okay, now these two topics in my respective perspective is that they are a little bit shorter compared to the practice, because a lot of the drugs are overlapping. Since we spend so much time in psoriasis, a lot of the maps, so-called, are overlapping, having dual indications for RA and as well as psoriasis. Okay, and a lot of the real immunological etiology of these autoimmune disease, we went over those in immunology. That's why I'm also skipping those in these material. All right. Okay. Without further talking of these random info, let's go into the material. So systemic lupus erythematosus, systemic, it's affecting all organs. Okay. And lupus basically is wolf, but it's also referring to a lot of the skin conditions, and particularly for erythematosus, there is this characteristic butterfly rash. Okay, butterfly rash here on this is very characteristic for the conditions. Is a butterfly? Okay, and there could be systemic attack against different organs. Here we are showing it could be lung, heart, lupus, arthritis, and also other conditions as well. Okay, there's a drug index. Some of those are non-specific, like NSAID. They are non-specific for SLE. They're used everywhere. I'm not going to talk about NSAID. You've heard quite enough, I believe. I'll touch upon on certain anti-malarial drugs that can be used for SLE. Glucocorticoid, again, those things are repeating itself. I won't talk about it. Particularly, I will focus on some of the cytotoxic or immunosuppressive agents for the conditions. Learning objective will describe the mechanism of actions of various agents that are used to treat SLE, as well as relating some mechanism to the physiological and molecular pathophysiology. Right, let's look at this overview of the conditions. So it ties back to the immunology lecture that we talked about last week. It is an autoimmune disease and potentially affecting every organs in the body. In terms of the symptomatic presentation on the skin, there is this butterfly type of lesions, or not lesions, of redness, and can also affecting kidney, being one of the more common organ affected. There's some statistics showing that at least 1.5 million Americans are living SLE, and there are about 16,000 new cases annually being diagnosed, mostly affecting women, and we talked about how high estrogen can exacerbate with the conditions, right, leading to more of an antibody mediated response. Okay, now the 15-year survival rate with treatments about 80%. Let's take a look at the pathophysiology and etiology in a very brief term to describe the condition as a dysregulations of B cells and T cells, and having a productions of autoantibody, particularly those are anti-nuclear component antibodies. Okay, and leading to formations of immune complexes, leading to activations of complement cascade, and leading also further down lead to disruptions of the cell or destructions of the cells and affecting the organ system. The exact cause, like many diseases, autoimmune diseases, it's very much unknown in many cases. It could be a combination of environments, genetics, and hormonal factors, and in particular, high estrogen. Oh, very terrible handwriting. Still cannot get used to it very well. Alright, so there are also drug causes. Some of the examples, it could be drug induced. Now I won't ask you on my material in terms of what drug, so that's why I'm going pretty brief in this sense. So pharmacological treatments, it could be NSAIDs. Okay, these are very non-specific. We could also use anti-malarial like hydroxychloroquine or chloroquine, which is pretty hot topic these days because of the COVID-19, right? Now the exact mechanism, okay, is really unknown. Okay, something anti-malarial and how it helped SLE, it's not entirely clear. It could be some of the immunosuppressive or anti-inflammatory or combinations of both. It may also block UV like absorptions. So it we see it worked in some way, but we don't know what it's the real target is being affected by these drugs in these conditions. Right, glucocorticoids such as prednisone, basically you are trying to suppress some of the inflammatory processes. Okay, now this dysregulations of T cells and B cells, one of the way to stop these dysregulations is to kill it off. Okay, we could use cytotoxic agents. Okay, and also immunosuppressive agents to suppress its activations. Now we also have a particular biologics that is specifically for SLE. This one is specific for SLE. Now first look at the immunosuppressive drug, cyclophosphamide. Okay, we talked about it in the immunology. Now we are really talking about the deep down pharmacology of what's going on, or some of the transformations of these drugs before it can act as a drug. Now, again, you don't need to memorize these structures. Okay, here we have a cyclophosphamide drug here showing you on the right-hand side. Like I said, I always like to show a structure, but in this case, it is relevant of showing it. It is a chiroprodrug. Okay, remember the definitions of prodrug. So it needs to be transformed into a active one. Okay, if it by itself, okay, active drug. Prodrug transformed into active drug. So here coming down, okay, looking at this transformation pathway down at the bottom of the screen, first we have cyclophosphamide being a prodrug. Okay, first it needs to undergo a hydroxylation process at the C4 on the ring structure here. Here is the carbon 4. I put a 4 here, carbon 4 positions, and this reaction is primarily done by CYP2B6, B for boy, 2B6. Now 3A4 can also do the job, but majority, primarily, means the majority of this job is done by cytochrome P450 2B6. Right, so it add a OH group, hydroxylation reactions must happen. This must happen before you can transport into the cell. Alright, so we are doing things to the cell, and this step need to be happened. Very, very important, very important. So these things are will be asked in on exam. I'm very very honest, and you have to understand the implications of why this hydroxylation. Why hydroxylation? Because it need to go into the it need to be transport. Transport. It's not simply by not diffusions. Let's write it down so that everyone would remember. Not diffusion, it need to be transported. Now once it's transport, coming down, this is the same slide with one more step. Now the drug will also need to be hydrolyzed. It need to be hydrolyzed. So the ring will be popped open. In both stage they can be transported into the cell. So it could be being transported as a ring structure into the cell and then undergo hydrolysis, or it could be hydrolyzed or hydrolysis first and then go into the cell. So these two steps doesn't quite matter in terms of when this hydrolysis happen. It could be both inside or outside of the cell. Once it goes into the cells, this compound will need to be go through a spontaneous beta eliminations. Okay, I don't know if you remember, okay, organic chems, okay, this compounds will need to be undergo beta elimination. Pop out the COH, okay, and this compound, okay, equivalents are being eliminated. Now you have phosphamide mustard, okay, being trapped in the cell because it's so much charged, it's now being permanently trapped into the cell. Now, phosphamide mustard then form a ring. So this is a continuation, okay, from the previous slide there. Okay, again, here is the mustard agent, and now it need to form a ring. So it starts with a ring and then being popped open, and then it form a ring again after it's being inside the cell. Okay, form a quaternary aziridinium ions. Okay, it forms a ring. Now this ring, what it does, now it's at this stage, it's finally doing its job. It's to alkylate DNA. Basically, you are linking, okay, cross-linking the DNA at the guanine base. Okay, at the guanine base is a preferred nucleic acid base being chained together as shown in this graph here. Ultimately, you have two strands stick together and permanently. Now you have two strands being stick together. Basically it is a DNA damage. Okay, DNA damage. No replications happens. No replications. Cell death. You killed off the cell. All right. So it's cytotoxic. Okay, in nature. Now moving on to the second agent, okay, azathioprine, okay, azathioprine. Okay, so it is again a prodrug, okay, a prodrug of 6-mercaptopurine here. Now, 6-mercaptopurine itself is also a prodrug, so this gives you a twist. Okay, it is a prodrug of a prodrug. Okay, so this is mercaptopurine. This is the prodrug of a prodrug. It's converted to ribonucleotide by this particular enzyme, HGPRT, hypoxanthine guanine phosphoribosol transferase. Very long name, and this abbreviations will be suffice. Okay, so it transformed into by this enzyme, it finally become a active thiopurine ribonucleotide. Okay, it's a thio compound. So once the drug becomes the active compound, it basically have two mechanisms. First one is inhibiting this aminophosphorus nuclease transferase. Okay, sorry about that. This is a very long name. Inhibit this enzyme. Now this enzyme is a rate-limiting enzyme for AMP and GMP synthesis, and it will lower the amount of AMP and GMP, okay, by inhibitions. And additionally, this guy looks so much like AMP and GMP down here, and it will incorporate, as an analog into DNA and RNA synthesis. Okay, what happens then is to stop elongation. You are basically inserting something that will not promote further elongations in those, in the polymerase reactions. You stopped it, leading to cell death, and you are decreasing the B cells and T cells, particularly those cells that are highly dividing, they are rapidly dividing. Alright, moving on to the next drug. Now, this drug usually is abbreviated as MMF, Mycophenolate mofetil. Again, this is a prodrug. So, there's a lot of prodrug in this particular theme. Notice which one of those are prodrugs. So, MMF is a prodrug of this mycophenolic acid. The myco name kind of give you a hint. They are from fungus in the Penicillium species. Okay, they are a bio compound, so called. So what it does is to reversibly inhibit the inosine monophosphate dehydrogenase, another enzyme. No, so this this lecture, this chapter get clear with all these enzyme, which one is inhibiting which enzyme, it would be useful to make a chart. Okay, we have a drug list and a target list. Okay, target T-A-R-G-T, sorry, and then you can also have an additional column indicating is this pro drug. Okay, is it question pro drug? You can do some check mark on there. Okay, I think that would be quite helpful for you to organize the material in the preparations for exam 2. Okay, all these are on exam 2 coming up in a couple weeks. So coming back to the main content, it reversibly inhibit this particular enzyme. This enzyme is involved in GMP synthesis. Okay, guanosine nucleotide synthesis. Again, you are taking out the raw material for DNA synthesis. You decrease proliferations and particularly the of B cells and T cells. Now, coming to the last drug, okay, last drug that is specific for SLE is this biological agents, this Betalutamide. Okay, Betalutamide is a fully human monoclonal antibody. It inhibits a B cell stimulator, okay, BLYS, which is required for the development and survival of B cells. Now remember, these conditions, SLE, are tied to autoantibody, and we know B cells, further down developing will lead to antibody secretion. So you are, stopping it in an early stage. Okay, early stage, you're stopping the activating factor from binding to B cells, and B cells will go to apoptosis. Right, and it has been shown that a decreased level of BLYS level are associated with improvement in the SLE. Now, this drug, this biologics, okay, is specifically approved for SLE back in the days, March 2011. So that's all for me on the SLE. So like I said, it's not that much, and I'm not going to ask any in the middle questions for this topic, and we will take a blank slide and move on to rheumatoid arthritis. So rheumatoid arthritis. So again, here is just a graph showing you the conditions. Again, there are inflammations, cellular damage associated with the conditions. Alright, let's look at the drug index for RA. So I break down based on categories. First, we have the biological DMARD, disease-modifying agents, and we have TNF-alpha blockers. A little bit more potentially. This one is not on the psoriasis, but the mechanism of actions are similar. And then we have something that is specific for anti-B cells, anti-T cells, and then also bind to our IL-1 receptor, okay, as an antagonist, and also IL-6 receptor as an antagonist. We have more conventional synthetic, i.e. small molecule drugs that are listed here. All right, and we talked about most of those already. And targeted synthetic DMARD, okay, these are specific, these are NIP, okay, NIP, when I mentioned earlier on in the biologics, okay, these NIP issue are some of those fancy, I think they are fancy small molecules, okay, they're fancy small molecules. Learning objectives: briefly explain the pathophysiology of RA, very brief, okay, and describe mechanisms of actions of the drug that are presented in this topic. Alright, rheumatoid arthritis primarily involve the joint, okay? Incidence between 0.5 to 1%. It have been some observation. There are high prevalence in some Native American populations. Definitely there is a positive family history tied into it. Now, there are also there seem to have some increased rate in twins. Remember, there is this allele, distributions we talked about in immunology, have been, for example, like the diabetes. Okay, these the potential linkage to it. All right, let's erase this. Let's not get confused with this. Right, genetic implications and plus other factors can also involve, like could be environmental, could be infections, and all these. Alright, so here is a very basic, graphical rundowns of the pathway to the rheumatoid arthritis. Okay, so here are, we know that there could be some genetic susceptibility. You don't need to memorize these little terms here. Just focus on the big picture. Plus some type of environmental factors, okay, perhaps it's infections, okay, sharing the homologous peptide epitope could be, okay, between the infections and your self antigens, okay. It could be some epigenetic modification, okay. We're talking about methylations and things of that nature, and it could be some post-translation modifications to the protein. All in all, in combinations, right, leading to loss of self-tolerance that we talked about, loss of self-tolerance, and starting having a first some cellular infiltration. So you have these T cells going into the areas. At that point, they are a little bit more asymptomatic, and over the time, there is manifestations leading to swelling, pain, stiffness, and damage. Led by many of the inflammatory mediators that we've been talking about for a long time. Now here again is a graph, okay, showing you at the anatomical level or biology anatomical positions. There's the normal joint on the left, and then the rheumatoid arthritic joints on the right. Clearly, these places, okay, should not have all these immune cells, but on here they're showing you, okay, you have all these immune cells being present that in the normal circumstances it shouldn't be. Plasma cells and T cells, B cells, and everything, macrophages. Alright, so looking down into the cellular biology level here. Now, a lot of the familiar, okay, or not familiar, graph showing you the activations of T cells by antigen presenting cells, okay, and then there are different interleukins being involved. Now, particularly, there is this several of those highlight is an elevated level of IL-1, okay, increase in IL-1, may be responsible for some of the hallmarks of rheumatoid arthritis, such as cartilage degradations, bone reabsorptions, and other autoinflammatory symptoms. Okay, this particular IL-1 here, okay, leading to changes at the cartilage and bone level. Again, now this is molecular level of what is going on, okay, at the within a cell, within a lot of the immune cells. So here are some of very complicated self-signaling pathway here, NF-kappa B being one of those, and also this new one is JAK, okay, JAK signaling cascade. Now we're going to talk about JAK and drugs that modulate this JAK signaling pathway toward the end of this topic. Alright, so here is a table that I adopted. So there's FYI for me. I am not going to ask you any of the particular information, and particularly on doses, but I think here is a nice grouping of breaking down between conventional synthetic DMAR listed in here. What are they? Small molecules, biologics, okay, biologics, what are they? So it gives you a very good rundown of this, which is a chimeric antibody, which one is the human antibody, and there we have fragments as well, and also we have a fusions, okay, a Abatacept, okay, this Cept thing is a fusions between a receptors and the IgGs, okay, so it's a fusion protein. So it's a very nice rundown, at least as far as I'm concerned, and we have target synthetic DMAR. Now, so this one is table, it's a little old, being 2 years old. It's a little old already. So we have a new agent that is in this category. We have a new one which we'll go over that briefly on the last slide. All right, quick recap. Okay, quick recap of TNF alpha blocker, which we talked about those extensively in the psoriasis. Okay, in the psoriasis already. All right, quick recap again. The chimeric or non-chimeric type of a concept, and this also shows you the pegulations and epitope binding. Okay, so all these things you should be very familiar already. Alright, so this is just a example of how these medications are being administered. It comes in a pen, almost like a like an EpiPen. In many cases, you inject yourself. Now Humira, being an older one, needs more injections compared to some of the newer agents where it requires less injection. Less injections is better in my opinion for patients. So rituximab is interesting in a sense that it can bind to B cells. So rituximab bind to the B cell, in particular the CD20. Okay, CD20 co-receptors on the B cell, and it will lead to complement activation, almost like a classical pathway leading to MAC and cell lysis. Also lead to apoptosis itself, and as well as leading to attractions. Basically, you're clothing, coating up the antibody-dependent cell-mediated cytotoxicity, and attract macrophages and monocyte different phagocytic cells come to interact with the B cells, and eventually leading to cell lysis as well. So these rituximab are trying to kill off some of these overreactive B cells that is happening with the conditions. Okay, so Abatacept, it's a fusion. Okay, it's a fusion. It is a fake receptor. Okay, it's a fake receptor that can interact with the CD80 or CD86 on antigen presenting cell, APC, such as the dendritic cells, and preventing co-stimulatory process of on the CD28 co-receptors on the T cell. So you are blocking the T cell activations, attenuating T cell activations. So the receptor it's very, mimicry, very similar to the CD28 receptor. On the other hand, we have a fusion stamp from the antibody. All right. Kineric. Okay, kineric. Okay, no, you notice the name. It is not a map. Actually, it is a amino acid or small peptide contained 153 amino acid sequence. So it's a small peptide. Now here on the left hand side of this graph that I circled, showing you a normal pathway where activated macrophages secrete IL-1, bind to its receptor, leading to signaling events and activations. And this particular drug actually acts as a receptor antagonist, IL-1 receptor antagonist, that bind to one of the dimers of this IL-1 receptors and inhibit, block the site so that IL-1 cannot go into binding and leading to signal transductions and activation. So you block the activations down the road. Alright, coming to this one is a biological map. Okay, it's an antibody, tocilizumab, I believe that's how it's pronounced. Now, coming into this graph shows you how different cytokines, in particularly one of those IL-6, have a role in causing bone destructions and cartilage destructions. So what if we can, find something to stop the actions of IL-6? Right here, where this drug comes, this biologic comes in. Okay, tocilizumab actually binds to both soluble form of IL-6 receptors and as well as membrane bound IL-6 receptors. Once it blocks the receptors, the IL-6 will not be able to bind to its corresponding receptors, leading to IL-6 signaling inhibitions and therefore stopping some of the downstream destructions that is happening on the bone and cartilage level. Now, we're going to talk about very briefly on the synthetic DMARD, disease modifying agents, and particularly one of those that we have not talked about previously, which is the sulfasalazine, okay, which that is a prodrug. Now, sulfasalazine is converted by this azoreductase in the colon by bacteria, colonic bacteria, and turned into 5-ASA and sulfapyridine. Like so, two compounds. 5-ASA can actually inhibit prostaglandins and interleukin synthesis, and also act as a free radical scavenger and act as a immunosuppressive agent. And sulfapyridine, on the other hand, can have a ability to inhibit bacterial synthesis of folic acid. So you have two effects coming off from it. So it will decrease some of the colonic bacteria load by this drug. Right, we come to this Leflunomide. Okay, again, this is a prodrug. Notice which one is prodrug, which one is not. Now, this drug, it's being reacted. Okay, basically there is a ring opening, okay, event which occurred in vivo, okay, inside the body. Then it can interconvert between the E and Z enolic forms. Okay, the Z enol are more stable form. Okay, therefore they are the predominant form. Okay, the Z form is more stable in a sense. It acts as a pyrimidine synthesis inhibitor by binding or inhibit this dihydrourate dehydrogenase. Here just a graph showing, trying to give you a sense of what's going on. Dihydrourate, okay, you stop this process, there's no urate, and therefore down the road, okay, stopping the pyrimidine nucleotide synthesis and no DNA and RNA synthesis. And the end result, you're killing off, inhibit reproductions of rapidly dividing cells, especially lymphocytes. So down to the road, the result is always the same. You just try to inhibit different target, different enzymes along the way of a cell that is responsible or that is important for cell reproductions. Alright, so this is one of those new drugs, okay, that are very commonly being advertised on commercial. This is one of those few ones that I constantly see on commercial. Xeljanz. Like if you watch any of the TV, you probably would have seen this Xeljanz on commercial. There's a lady that have some type of condition. She didn't look like there were conditions, and there's depicting some family. There's a little daughter of hers. Okay. You trust me, you must have seen it. Okay, this is the first one. Okay, first one. Xeljanz is the first one in this group, which is a JAK kinase inhibitor. Okay, JAK inhibitor, Janus kinase inhibitor. So let's look at some of this pathway before we talked about this drug, how JAK plays a role into this disease. Now, in response to the chemokines and cytokines, B cells and T cells and macrophages and other leukocytes, enter the synovium. Okay, the synovium, which is showed, in here in the process here. These activated immune cells produce cytokines that we've been talking about, pro-inflammatory cytokines, which signal through the JAK pathway. Actually, these cytokines are signaling through this JAK pathway, leading to productions of new pro-inflammatory mediator. Different inflammatory cytokines and propagate a cycle of chronic inflammation. So basically, this is a further, it's a keep going, further recruitment of activated cells, and you just make the conditions worse and worse. And this JAK pathway appeared to be a crucial step for this cycles to happen. And once we identify this pathway, let's do something to interrupt it, right? And here is this medication come from. Like Xeljanz, it's an oral medication, so it is good. In the commercial, they always tells you, hey, this is an oral medication. You don't need to inject yourself. It's very good. Here is a graph, okay, here that is comparing what has happened and before, people taking this Xeljanz. Before that, we talked about having a active JAK pathway will lead to many of the cytokine production. Now, don't worry too much about these fine detail here. All right, I want you to focus on more of the beginning and the end. Okay, beginning and the end in those. There are just many other informations. I don't want you to get too caught up on the specific details in between here. And after JAK inhibitions, you are having this drug bind to the JAK protein, ultimately lead to downregulations of productions of cytokines. The theme is very much the same. You are blocking the transcription translations, so it's old story in many sense. Now we have a final one. This is a newer one, okay, under the same group. Olumiant. I haven't seen this on commercial yet. It's quite new. But it does the same thing. Now, in case you wonder what this stat would stand for, I kind of forgot to talk about it on the previous slide. A signal transducer and activator transcriptions protein. That's all that is. So it goes into this goes into the nucleus and bind to the promoter regions of inflammatory cytokines, leading to transcriptions and translations later on of the cytokines. Okay, so it is always this old story. And having this new drug, another JAK kinase pathway, it binds to the JAK protein, stopping all these the dephosphorylations. It stopped the phosphorylations and preventing it being active and leading to transcriptions, leading to binding as a transcriptional element. Alright, so that is all. Very, very quick rundown of this topic. You can see the theme quite similar. Get clear with which one are the prodrug and which one are not. I don't think the pharmacology of these drugs are particularly challenging. Knowing which target, it's more important in my opinion. Okay, so let's go look at some questions and wrap up this particular topic. Alright, we are back from the lecture. Again, it is a little bit long, but instead of breaking it up into two, I just went through it with a single shot. Alright, so this is the end of my lecture series in the J module. It is a very quick 3 lecture. Now, it didn't take me 3 days to film it. Apparently, I'm wearing the same shirt in all 3 videos. That gives you a hint that I'm probably shooting these scenes one by one after each one. But anyhow, instead of talking about how I shoot my videos, let's move on to a more exciting topic, which is continuing the millionaire type questions. And today we are going to look at the $400 questions. Okay, which of the following is specific for SLE? Okay, systemic lupus erythematosus. That was a very difficult word for me to say. Anyhow, first option, belamumab. B, Rituximab. And C, tocilizumab. And D, adalimumab. Alright, all of those are quite challenging for me to say. And if you listen to the lecture carefully, and you would almost know the answer immediately. Again, these are very basic assessments to see if you are paying attention or if you are falling asleep. with my voice. Alright, 5 seconds. 1, 2, 3, 4, 5. And final answer is A, Belimumab. Now, Belimumab is approved specifically for SLE, unlike many other biologics that are cross-indicated with psoriasis and rheumatoid arthritis. And let's look at one more question, and that is our final questions for this series, which is a $800 question. It's not anything more difficult, it is just looking at a different topic, that's all. Alright, which of the following is targeted in RA or in RA treatment? First, A is Janus kinase. B, autoantibodies. C, IL-17A receptor. And D, IL-23. This requires maybe a little bit thinking, but again, if you pay attention by the process of eliminations, you should be able to quickly identify the target that is being targeted with in the treatment of RA. So I give you 5 seconds. 1, 2, 3, 4, 5. 5 seconds, and the answer, final answer is A, Janus kinase, or JAK, J-A-K. Alright, so we have this, we have two agents, actually two small molecule agents currently that is targeting the JAK pathway. So this is the end of my content in the GEM module, and I will be available for virtual office according to the syllabus or the schedule you receive in the GEM module. Of course, I'll continue to see you in the immunology and biotechnology class, and I hope you are not gonna get bored with me, and I'll see you